Well, here we go on the facial muscles, and I think one of the hardest areas is the tongue. That's what we're looking at here. This is the genioglossus. Its job is to depress the tongue. And it's also important because when we administer anesthesia, we are going to see this muscle shift posteriorly and block that airway. And that's why we have to often run a intubation tube past that area and down into the trachea. Okay, so we have the genioglossus, then we have the hyoglossus, and when that contracts, this muscle here, then you're going to see depression of the tongue. The tongue is going to go down. Then we have the styloglossus attached to the styloid process here on the skull, and that's going to elevate the tongue. Think about that. When that muscle shortens, contracts, then the tongue is going to go up. And finally, the palatoglossus, which is, we can't see it from this view. It's going to be in the palate, kind of underneath here. Okay, we'll get to that, all of that. Facial muscles, many of them are attached to bone or fascia. We call these extrinsic when they're attached outside of the muscle themselves. Intrinsic is when it's in the muscle, and I'll be talking about extrinsic here. Occipital frontalis has an anterior in the front and a posterior, held together by a sheet of tendon. The aponeurosis here, epicranial, epi meaning above, cranium. Orbicularis oculi, this is one that closes the eye. It's a huge muscle, but we need a muscle that's going to open the eye. And there we have the levator palpebrae superioris. Zygomaticus brings the angle of the mouth superiorly, so that means upwards, and laterally, so that's our smile muscle right there. Look at that zygomaticus major. It's larger than the minor, and see where it's attached? So when that contracts and shortens, you can just see that corner of the mouth come up in a smile. The minor elevates the upper lip, exposing the teeth. You might wonder, well, why do we need that facial expression? Well, in many primates, exposing the teeth is a way we avoid conflict. You may be seeing dogs do that. It's like, leave me alone. Look at my teeth. Do you want those biting your arm? No, I didn't think so. Okay, so we have a history too of being beasts. Buccinator, or buccinator, however you want to pronounce it, compresses the cheeks like when you're blowing, sucking, and chewing. This muscle right here. You usually can't see it because the masseter medialis, the masseter muscle, is covering it up. I mean, you can catch some of it if someone has a very well-developed buccinator. Orbicularis oris, the kissing muscle. It is a sphincter, just like the oculi is. It surrounds an orifice. It's going to close and protrude the lips. Levator labii. Okay, look at that name. Okay, levator means to lift. Labii, think of lips. Superioris, we think of superior. So it's going to raise the upper lips right here. A little bit of snarling action. Depressor anguli, so it's going to bring down. Oris means mouth. So it's going to bring the mouth back and laterally. It's in an open mouth. The depressor labii inferioris, so labii again, lips. Lower lips, it's going to depress the lower lip. So really the names of these muscles describe what they do. It's really nice that way. Risorius, now that name doesn't really describe what it does. It's going to bring the mouth laterally and back. Let's see, risorius, take a look up here. You can see the risorius there. So when that contracts, then we're going to have this grimace, which is, that's a good grimace. I found that picture. And mentalis, look at the mentalis here, centrally located on the chin. And when that contracts, we get this pouting action there. That's a great pout. And if you like pouting, we even have more pouting muscles, such as the platysma. It's a huge apron of tissue going down the anterior surface of the neck. The corrugator supercilii, right here. Now, you don't often see this one well because it is covered by the orbicularis oculi, excuse me. But there it is in the deep view. It causes those wrinkles when we are unhappy. Bell's palsy. This is an example. I think this is, yes, Sylvester Stallone. Some people that have Bell's palsy and about 80% recover, but they often have a little left over. And what's happening is it's facial nerve number 7. And what causes it? Sometimes herpes simplex, inflammation, ear infections, or surgery. And it's a stroke-like symptom. So you can take a look on the left side of this individual. You'll see a drooping of the eye. There we go. Sometimes there's pain. Drooling is fairly common. And there's different degrees of this. Sometimes it's barely noticeable. Continuing with facial muscles, masseter, I mentioned earlier, that's one of the largest chewing muscles. Mastication is the technical word for chewing. Insertion on the angle in the ramus, right here, take a look, of the mandible. There's the, well, that's first the temporalis, yeah, okay. All right, so, and insertion of, the origin on the maxilla and the zygomatic. Zygomatic is the cheekbone here. Temporalis, another huge muscle for chewing. Insertion on the coronoid, that's what I was getting a little confused here. This is the coronoid. It's the frontal process of the jawbone. There's a coracoid in the back. And of course the origin on the temporal bone here. Good name for that muscle. So these are the two powerful chewing muscles. The medial and lateral pterygoids, very difficult to see. They're deep. And sometimes you have to have, you have to strip away layers of muscles to see these. They come in at an angle. These are the only muscles that open the mouth, and so sometimes you'll see senior citizens with their mouth wide open, and that's often because these larger muscles start to diminish with age. You know, it doesn't have to be that way. If you can keep chewing food, but what happens is people get lazy and they start eating soft muffins and yogurts and everything soft, and no more carrots, no more steak, no more tough foods. So you can maintain these as you age. On to the eye. Okay, certainly a good facial muscle. Now there are intrinsic muscles of the eye. We're going to look at the extrinsic, and I like their names. They're very fast. In fact, some of the fastest muscles in the body and the most precise muscles are right here. Look at the rectus. There's 4 rectices. Rectices is plural. And they do exactly what their name says. So you have the superior. It's going to move the eyeball up. Inferior, move the eye down. Lateral, move it laterally. Medial, move it medial. Now strabismus is when we have a congestion with extrinsic muscles. Okay, there's lots of eyesight disorders. I'm not going to cover them because this is about muscles. So this is when both eyeballs are not aligned. And there's lots of reasons for this. And what happens is different parts of the brain get different images, and so the brain gets selective, and it says, well, I'm going to choose this image and I'm going to ignore the other one. And so the one eye starts looking lazy. Take a look here in this diagram. You see kind of a lazy eye. It can be constant or intermittent, meaning that it may come and go. And I mentioned there's lots of factors that cause it. Nice picture here of the rectices, lateral, medial, superior. I'll talk about the trochlea shortly, so just keep your mind, or keep this in mind. The trochlea is this little hook, like a pulley hook. The superior oblique passes through that loop of cartilage called the trochlea I just talked about. And let's see, there's the trochlea, lower diagram. And there's the superior oblique right here. Do you see that? So just as the name implies, it is on the superior upper part of the eye, and it comes at an angle. The tendon of this muscle is going to expand on the posterior lateral part of the eye. So that means the back lateral side of the eye. Okay, levator palpebrae superioris. We did look at this a little while ago, and here it is coming. Now it doesn't involve movement of the eyeball. Can you see the rectices certainly attached? Excuse me, they're inserted onto the eyeball itself. But here the palpebrae is not, but it does help the upper eyelid to open. Its antagonist, the orbicularis oculi, which you can't see in this picture, but we've seen it before. It's a huge sphincter muscle around there. Inferior oblique originates on the maxilla, so if it's inferior, it's going to be below. And it comes in an angle, and so you get that side-to-side movement with a little multi-directional. If you ever raised a teenage girl, you get to see the inferior oblique a lot when they roll their eyes at you because you're an idiot. Okay, on to the tongue. Tongue is probably the most difficult of the structures, and that's why I gave us that little preview. When we, well, let's just take a look at them. Genioglossus is the one that I mentioned earlier. Let's find it. Genioglossus, here it is. It's massive. So let's find the tongue, and that's why I put this second diagram here. Let's take a look at this one. So you can see the muscles of the genioglossus. Glossus means tongue. So when you see that word, think tongue. These are all extrinsic, meaning they originate outside the tongue. And this is the one that I mentioned. It drops back. And take a look at the lower diagram. The genioglossus is going to drop and block the airway, and so the trachea. And that's why we have a trach tube or endotracheal intubation is the full name. I like this diagram. That's why I selected it, because sometimes you see medical shows or movies, and someone's got a blocked airway, and then they go and do the trach insertion of a ballpoint pen or something, and everyone thinks it's so heroic. But I always think if they had a nasogastric tube or some kind of NPO, they could just do away with all this complicated surgery and slip an airway, and you put a little Vaseline on it. Make sure there's a bevel. You see the bevel on the end, and you always run the bevel on the medial side of the nares. And you check both nostrils, by the way, because sometimes there's a deviated septum. Get a little pin flashlight, take a look up there, and see which one's open. Lubricate that baby, and have the patient sniff. Sniff it, and when it hits here, swallow, 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 swallow. It's not so bad. Stauglossus elevates the tongue and brings it posterior. Let's see this. We saw the stauglossus in the entry video right here. Hyoglossus depresses the tongue, brings it down on its sides. I don't care so much about the sides. Let's focus on depressing the tongue. Palatoglossus we couldn't see in the intro video because it is attached to the palate, the soft palate, and that's where we get the movement of the palate towards the tongue. And it does elevate the tongue as well a little bit, you can see here. All right, thanks for listening.